Okay.
Yes, full screen, sir. So visible.
Okay.
Okay, sir. Okay, okay.
So we are some way we are witnessing a silent epidemic in India. The latest being fatty liver. So fatty liver has emerged as a major public health problem and cause of chronic liver disease globally and also in India. NASH, that is non-alcoholic steatohepatitis, has emerged as the most important cause for cryptogenic cirrhosis and hepatocellular carcinoma. So the Indian data suggests that non-alcoholic fatty liver disease is not only an important cause for unexplained rise in hepatic transaminases, but an important cause of cryptogenic cirrhosis and non-hepatitis B virus, non-hepatitis C virus, hepatocellular carcinoma. So it's also becoming an important indication for liver transplantation in our country. In addition to the increasing risk of hepatocellular carcinoma in patients with NASH cirrhosis, the non-alcoholic fatty liver disease is emerging as an important cause of hepatocellular carcinoma in patients even without cirrhosis or advanced cirrhosis, fibrosis. That's very alarming statement. So they don't have to go through that stages for developing hepatocellular carcinoma. The risk of chronic kidney disease and fatal and non-fatal cardiovascular disease has been shown to increase in patients with NAFLD independent of the presence of metabolic risk factors. That's why this topic is very important. And NAFLD has also been associated with many other extrahepatic conditions, including osteopenia and osteoporosis, OSA, obstructive sleep apnea, hypothyroidism, and PCOS. So in addition to hepatocellular carcinoma, there are other extrahepatic malignancies. The risk, especially for carcinoma of the colon, CA stomach, CA pancreas, CA uterus, and breast carcinoma, in the tune of 1.5 to 2 times higher risk of developing these the extrahepatic cancers. Now coming to the NAFLD prevalence, the global and the Indian scenario, around 25% of the world population are already having NAFLD. And when it comes to India, it is around 38.6%, and it is much higher, especially in patients with metabolic disorders like type 2 diabetes, obesity, dyslipidemia, and hypertension, and many of the components of the metabolic syndrome. In pediatric group also, many of the reports, the latest being from the Delhi, also shows that it's the prevalence is at par with the adult population. So the NAFLD has also got a close association with many of the other metabolic conditions like obesity, type 2 diabetes, hypertension, the high triglyceride, low HDL, the typical atherogenic diabetic dyslipidemia, what we usually see in type 2 diabetic patients, and metabolic syndrome. So in MASLD, it's not only because it's a cause for a cause of death, but mostly the cause of death is not because of the liver related illness like the cirrhosis or the hepatocellular malignancy. It's mostly because of the cardiovascular disease, because they follow the common soil hypothesis. Now coming to the prevalence of CLD risk factors in India, it actually is at par. The gap is narrowing down when we compare with the alcohol-related drinking habits. That is followed by the hepatitis C virus and hepatitis B virus infections. So there is a debate going on in the academic circle on the change in nomenclature from fatty liver to NAFLD versus MAFLD versus MASLD. Let's update on this area because it's interesting. So the name NAFLD, the people who are they are suggesting for a change in the nomenclature says that the name NAFLD is heterogeneous and it's based on a negative criteria, the sort of diagnosis of exclusion. So the metabolic risk factors which are so commonly associated that we have seen in the previous slides are not reflected in the name. So the word non also in non-alcoholic actually trivializes the importance of this metabolic condition. So, and again, the word alcohol in non-alcoholic is somewhat stigmatizing for the patients. And the people who still want to continue the old terminology says that mere change in the nomenclature doesn't is actually based on eminence rather than evidence. And the heterogeneous nature and the multifactorial pathogenesis are not going to change with the mere change in the nomenclature. And not going to become homogeneous also. So the again, the definition of metabolic dysfunction is not very clearly delineated. And again, because many other diseases still follow the prefix like NHL, non-Hodgkin's lymphoma, non-cirrhotic portal fibrosis, NCDs, and so on. So the prefix non does not trivialize these diseases. And again, similarly, the word non-alcoholic does not seem to be stigmatizing. So, and they further says that the patient may feel happier when they learn that their liver disease is not related to alcohol. So, and again, significant progress has been made in the last couple of years on the biomarker and the drug development areas for NAFLD. So, any change in the nomenclature may have a negative bearing on these efforts, and also for the people who are involved in the research area also. So, even though there are so many arguments there, but when you see the literature, most of the international organizations involved in the liver care and the recent literatures are also in favor of a change in the nomenclature from NAFLD to MASLD, that is metabolic dysfunction associated steatotic liver disease. This is now becoming the standard terminology in most of the recent journals. So steatotic means, by simple definition, if the liver fat content is more than 5%, we call it steatotic liver disease. And for making a clinical diagnosis of MASLD, we require at least one additional cardiometabolic factors in the form of elevated triglyceride or low HDL, the so-called atherogenic diabetic dyslipidemia, type 2 diabetes or a pre-diabetic state, obesity, especially the truncal obesity, and high blood pressure. So any one of these plus a liver fat content of more than 5%, we can make a clinical diagnosis of MASLD. Coming to the spectrum of NAFLD, so it comprises from one end non-alcoholic fatty liver to non-alcoholic steatohepatitis, means the inflammatory component, to steatosis with steatohepatitis with fibrosis, steatohepatitis with cirrhosis, steatohepatitis with hepatocellular carcinoma, that spectrum. So the NASH is a sort of severe form of NAFLD, which in addition to the hepatic steatosis is associated with hepatic inflammation and fibrosis, and has the highest propensity to progress to cirrhosis of the liver and hepatocellular carcinoma. That's why our focus is mainly on the NASH part of the NAFLD. So NAFLD may coexist with other liver diseases that can increase the severity of the fibrosis, especially in the context of the risk of cirrhosis and hepatocellular carcinoma if they have a coexisting chronic hepatitis B or a chronic hepatitis C, or even the alcohol-associated liver disease, ALD. So the Indian data suggests that many of these patients actually fall under the dual etiology fatty liver disease, we call DAFLD or DASH in the place of NAFLD and NASH, comprising of alcohol plus metabolic risk factors. That's not uncommon in clinical practice, and that ultimately increase the severity of the underlying liver disease. So traditionally, NASH has been considered to be a progressive form of the NAFLD. However, the current evidence suggests that there is a dynamic cycling between NAFLD and NASH. So somebody is having an NASH, especially the earlier part, without much of fibrosis. They can, if we intervene, they can go back to the NAFLD stage. Nonetheless, the progression of fibrosis is possibly faster in those with NA as such. That's why the NASH is the most important part. The presence of underlying fibrosis is the key determinant for both histological and clinical outcomes. So the progression of fibrosis is slow in the vast majority of patients. It takes many years, but altogether, but some patients, a quarter of patients, we can observe a rapid progression of the fibrosis stage.
Others, please mute. Others, please mute.
Thank you. So coming to the diagnostic part, even though most of these patients with NFLD are typically asymptomatic or by the incidental, the routine, when we ask for an ultrasonogram for a routine medical checkup, or if we are evaluating for a dyspepsia, or as a part of workup for isolated elevated transaminases, or some patients with type 2 diabetes, obesity, and metabolic syndrome as part of the general workup that has been recommended in the latest guidelines, we may come across this NAFLD diagnosis. So the diagnosis of NAFLD requires the documentation of hepatic steatosis, that is more than 5% fat content, of variable severity on imaging or histology, and at the same time, by excluding the secondary causes of hepatic steatosis. That's also very important because we most often make a clinical diagnosis with simple ultrasound. So testing for these alternate causes of steatosis should be tailored according to that clinical scenario. However, at least we had to do the HBsAg and the anti-HCV antibody in all these patients to rule out, again, the history of significant alcohol intake. These three things we had to take care to make a diagnosis of NAFLD. So how to go about in assessing the hepatic steatosis, that is the NAFLD part. So ultrasonograph remains the easiest and the simplest way of detecting the presence and also grade the severity of hepatic steatosis. So even though they have a limited by the accuracy, especially in the persons who has got a liver fat content less than 30%, and also having severe obesity, there is also an overall subjective element in the interpretation, but still the ultrasonogram remains the most preferred tool in the clinical scenario for diagnosing hepatic steatosis. So they are usually graded. You might have seen the ultrasonogram reports as mild fatty liver, moderate fatty liver, or severe fatty liver. Some people will write grade 1, 2, 3 based upon the presence of hepatic steatosis, blurring of intrahepatic vessels, and posterior attenuation seen as blurring of the diaphragm. So upon these findings, they will make a diagnosis of grade 1, 2, or 3. It has been shown in this slide. Grade 1 means increase. We usually compare with the echogenicity of the spleen and right kidney. So if the echogenicity of the liver is more than that of the spleen and right kidney, it is a grade 1 mild fatty liver. So if there is a blurring of the intravascular structures, we make a diagnosis of moderate MASLD. And if there is a deep attenuation of the ultrasound signal, the diaphragm cannot be readily discerned from the posterior surface of the liver, we make a diagnosis of severe MASLD, grade 3 MASLD. So now moving on to the assessment part of the hepatic fibrosis. So there are simple non-patented parameters available, especially blood tests available, like we can do the platelet count, the AST-ALT ratio, or some specific and validated scores are available. That also we can use, like AST to platelet ratio index. Very often we use this APRI, or the fibrosis 4 means there are 4 components like AST, ALT, age of the patient, and platelet count, or the NAFLD fibrosis 4 like NFS, comprising the body mass index, AST, ALT, albumin, and presence of insulin resistance and diabetes, and BARD score, that is BMI, age, AST, ALT ratio, and presence of diabetes. So the advantage of these scores are that they are readily available. We can use the bedside itself on the mobile phones or laptops, and there are cutoffs commonly being used either to rule in or rule out advanced fibrosis, clinically significant fibrosis or advanced fibrosis, with a rule-in and rule-in cutoff which has a high specificity and a rule-out cutoff which has a high sensitivity with an intervening gray zone. So that's an area where we had to proceed further. So of the all available, the above mentioned blood-based test, the FIB4 has shown to be the most accurate. This is again showing the why we use the FIB4 index to exclude the presence of clinically significant fibrosis, that's advanced fibrosis, by merely using 4 clinical parameters: the age of the patient, the AST, ALT values, and the platelet count. It's very easy, very cost effective, very quick. We can rule out the we can rule out the presence of advanced fibrosis with a high sensitivity and specificity, and has been recommended by all the major guidelines. The American, the INASL is Indian National Association for the Study of Liver, and the American Gastroenterology Association. This is a flow chart again showing we had to rule out other causes, especially someone with elevated liver enzymes. You take history of significant alcohol consumption. Think about a history of steatogenic medication use, something like steroids or methotrexate. Rule out chronic hepatitis B, hepatitis C infection by doing the antigen and antibody test. Then you can calculate the FIB4. If it falls below 1.3 means we are ruling out the advanced fibrosis. And if it is more than 1.3 or more means there is a chance for advanced fibrosis. There you may have to use other tests. We'll come to that. All these VCT, MRE, and ELF, we know what they are. This again shows the FIB4 index and the cardiovascular events. Has got a prognostic value as a marker in the risk assessment for not only liver events, the cardiovascular, because they go hand in hand, and ultimately the overall mortality also. So somebody having a FIB4 score of less than 1.3 means they have a low risk of not only the liver-related events and mortality, the CV-related events and mortality also. Somebody is having about 2.67 means they are at a high risk for developing and progression to the cirrhotic stage and hepatocellular carcinoma. The indeterminate, the gray zone, that's 1.3 to 2.67. We require additional modalities for further refining their the risk. So if the FIB4 is reducing means there is a reduction in the liver and CV related events. If the FIB4 is increasing, there is an increase in the liver and CV related events. That has been shown in this chart. So commenting on the non-invasive score, the AST platelet index, the fibrosis 4 index, and the NAFLD fibrosis score, the rule-out cutoff and the rule-in cutoffs we can see. So somebody is having less than 1.3, FIB4 means rule out, and 2 points above 2.7 means you are ruling in. And again, APR again less than 0.5, you are almost to rule out the possibility of advanced fibrosis, and something in the tune of 2 means there is a high likelihood of having advanced fibrosis. So with the increasing availability of the vibration control transient elastography, VCT, commonly we call it as FibroScan. Many of us might have used it, or many of our hospitals and laboratories having this facility right now across our country. So more clinicians are relying on this controlled attenuation parameter, or we call as CAP. You might have seen in the FibroScan report, CAP value for the presence and also the grading of the hepatic steatosis. So in contrast to the ultrasonogram, which is more of a subjective interpretation, the CAP has got an advantage of being more objective in the assessment of hepatic steatosis. So based on the studies showing a sensitivity of more than 90%, the European counterpart of ESL has recently recommended a cap cutoff of more than 275 decibel per milliwatt for the detection of hepatic steatosis, which has got a high sensitivity and a positive predictive value of more than 90% for detecting steatosis in NAFLD. So this is the machine, you might have seen this machine. using the VCT technology. So for the CAP is for the non-invasive quantification of the liver steatosis, and for the LSM, that is the, again you might have seen the LSM value. That is a liver stiffness measurement. That's for the non-invasive quantification of the liver fibrosis. So both these outputs are available with a FibroScan. So these are the usual scores. You can concentrate first on the understanding the CAP score for steatosis. For both non-obese and obese cutoffs are a little bit different. This grading is S0, S1, S2, and S3. S1, S2, S3 means mild, moderate, and severe. The G1, G2, G3, what we have already mentioned. And on the other side, we can see liver stiffness measurement with the kilopascal value. The 5 stages of absence of fibrosis, mild, moderate, and severe fibrosis, and the cirrhotic stage. You can see the values. So this is the one. Means somebody is having a S0 means the liver fat content is less than 11%. Grade 1 means it is somewhere around 11 to 33%. The grade 2 fatty liver, moderate fatty liver means 34 to 66% fat, and severe fatty liver, grade 3, S3 means more than 67% of the fat. So the APRI less than 0.45 or a FIF4 of less than 1.3, 1.2 or 1 we can rule out a significant fibrosis with a very high sensitivity. So at the tertiary care level, transient elastography can be used as the next step for confirming the degree of hepatic fibrosis if the APRI or the FIF4 score is more than 1.3. So the cutoffs of less than 6 kilopascal and more than or equal to 8.2 kilopascal on VCT, the FibroScan, for ruling out and ruling in significant fibrosis. That's the one we usually commonly have seen in the FibroScan reports. Liver, this again, liver stiffness measurement cutoffs for the FibroScan. F2 or significant fibrosis means somewhere more than 8.2 or more. F4 is cirrhotic stage, 13.6 or more. So the liver elastography has evolved over time as the most accurate tool for the non-invasive assessment of hepatic fibrosis. The new generation ultrasound machines also has an added facility. You might have seen some radiologists using the added the probe for shear wave elastography for simultaneous assessment of hepatic fibrosis. But of the all forms of elastography, the one available, the VCT technology, the FibroScan we are using, is having the maximum data, patient data. So even though the most accurate and having the advantage of assessing larger area of the liver, the MR elastography is limited because of the very high cost and again because of the logistic issue, the availability issue. So risk stratification, so the huge number of patients, actually a fraction of them will ultimately develop into clinically significant liver disease, fibrosis, cirrhosis, and hepatocellular carcinoma. So risk stratification and guidance on referral, when to refer using the non-invasive tests is need of the hour for optimal utilization of resource-limited healthcare setting like our country. So that's why this algorithm for diagnosis of MASLD is very important. So for some reasons, for routine health checkup or incidental finding or evaluation of patients with metabolic factors or incidental detection, follow-up of elevated liver enzyme, somehow we find a liver fatty liver on an ultrasonogram, then we will proceed with a non-invasive testing, especially the FIF4 or NFS. FIF4 is the one we usually use. And if it is comes as the cutoff less than 1.2 all, we will categorize into low risk, and that sort of patient require a repeat evaluation once in 2 to 3 years only. Somebody is having high 2.7 all, above 2.7 all, they fall under high risk. Or somebody between these two, the gray zone also, they require a FibroScan or the blood tests, what we have already mentioned for measuring the fibrosis markers. And if they fall under the low risk category, you can again repeat that in after 2 to 3 years. Or if they fall under the high risk category, you can refer to a gastroenterologist or a hepatologist, a tertiary care center for further evaluation and management. So various guidelines, the American, the European, Indian guidelines, the people involved in the liver care are recommended for MASLD screening for somebody having obesity, type 2 diabetes, or pre-diabetes with elevated liver enzymes, the diabetic dyslipidemia and hypertension. They all has to go for a MASLD screen. And the recommended initial screening parameters are the AST, ALT, platelet values. You can calculate the FIB4, and also you can go for an ultrasonogram. And this is one interesting slide. You can compare somebody is having diabetes makes so much difference in the NAFLD evaluation, because from NAFLD to NASH, NASH, only 10 to 20% usually progress. When it comes to the diabetic background, almost doubles to 40%. From NASH to cirrhosis, again 10 to 15% versus 20 to 25%. And some people directly go from NASH to hepatocellular carcinoma. There again, you can see 2% versus 16%. And from hepatocellular carcinoma to liver transplant, again, that's same because of the indication. But when it comes to cirrhosis to mortality, hepatocellular carcinoma to mortality, liver transplant to mortality, all these entities, those with a background diabetes have a very high risk of progression. So that's why somebody is having a metabolic dysfunction in the form of type 2 diabetes, having an obesity, they require a special attention and further workup. So when we routinely see somebody is having a fatty liver, look back and see the diabetic status. If they have diabetes, means they have a high risk for all this progression at a faster pace. This again shows the clinically very interesting slide. So type 2 diabetic patients, last year data. So 22.7% of patients had significant liver fibrosis. The highlight is that only 27.7 and 37.2% of the individuals had a clinically significant fibrosis with an elevated AST or ALT value. So don't look at whether they have an elevated AST or ALT value, then only proceed for further evaluation. Majority of the patients have a normal transaminase levels, especially in type 2 diabetes. So we have to screen these patients irrespective for liver fibrosis, irrespective of the transaminase level. Again, the NAFLD diabetes view and the prevalence of steatosis. You can see the steatosis is present in 75% of the type 2 diabetes patient, mostly 15, 24, and 36%. S1, S2, and S3, mild, moderate, and severe, mostly of S3. When it comes to the fibrosis side, the 29% have fibrosis, mostly contributed by the F1 stage. So stratification of patients with NAFLD at the primary and secondary healthcare levels can be done with simple scores like APRI and FIB4. If required, further evaluation at the tertiary care can be done with the elastography or liver biopsy. The National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke in India has recently integrated NAFLD for the first time in the world in 2021 into the national program, and also suggests a similar stratification and referral of patients to tertiary care centers. That's actually a welcoming movement, because many of these events go together. So what about a word about liver biopsy? Even though they are considered as the gold standard for the diagnosis of NAFLD and NASH, liver biopsy is in fact an imperfect tool, because there is a lot of sampling variability. There is a risk, small risk, but a significant risk of complications like pain, bleeding, and death. And moreover, it's difficult. If you want to assess the progress of the disease, very difficult and very almost impractical to repeat the liver biopsy for monitoring. And apart from the patient-related issues, other limitations like limited expertise or availability for doing liver biopsy, their interpretation, inter-observer and intra-observer variability, and the requirement for a tertiary care center for liver biopsy. All this makes the liver biopsy less attractive. And again, the acceptance part also is not very high. So, and at the same time, we can make a diagnosis of NFLD with clinically significant or advanced fibrosis in majority of the patient using non-invasive assessment without the need for liver biopsy. So, but in certain clinical scenarios where like if the non-invasive assessment is inconclusive, or if it falls in the gray zone 1.3 to 2.7, or when the patients have a confounding etiologies where you cannot differentiate from the other non-invasive modalities, there is an indication for liver biopsy and to make a diagnosis of NAFLD or NASH. So non-invasive modalities provide an useful information similar to that provided by a liver biopsy, with the added benefit of ease of doing and the safety to repeat the assessment if required. So the diagnosis of NASH cirrhosis, we are moving to the final part. The NASH cirrhosis requires the present or past histological evidence of steatohepatitis in the absence of other causes of steatohepatitis. Okay. So in clinical practice, however, the hepatic steatosis actually tends to decrease with increasing hepatitis. So as the fibrosis or the cirrhosis increases, the steatosis part comes down. So a diagnosis of NASH cirrhosis may have to be made in many patients without the present or a past histological evidence of steatohepatitis. That's also very important. Actually, this is one of the flow chart I want to show you, but it's very congested, and simply it is a summary of what we have already been discussed so far. So sorry for this slide. We'll move on. Coming to the sorry, the management part of MASLD. It's like any other lifestyle disease, a non-communicable disease. Lifestyle modification is the cornerstone of managing MASLD. Comprising of diet control and weight reduction in patients with obesity. And again, managing the comorbid conditions like obesity, diabetes, and metabolic syndrome. Then only comes the role of pharmacological therapy. So the 25% of the global adult population, it's mostly driven by a large part by the poor dietary habits because of the highly refined ultra processed food we are using, combination of red meat and added sugars, especially in communities where the better healthy food options are limited, harder to find. And eating smarter is the only way forward, and that can prevent liver diseases, but also can reverse the existing damage. The same like we say the diabetes remission or diabetes reversal. So it has shown to reduce the liver fat content, improving the liver function, biochemistry, and lowering the risk of liver related illness. So that's why this is the second reason why I have taken this topic today. The World Liver Day falls on 19th of April every year from 2010. And this year the theme is food is medicine. So the actionable insight should be make small but impactful changes. Try to make impactful changes in your daily diet. And that should be the advice to our patients. And coming to the management part, the weight loss in the tune of 3 to 5%, 7% or more, 10% or more for improving steatosis, steatohepatitis, and fibrosis. So as such, a weight loss of target of 7 to 10% is recommended in overweight and obese patients. The same as for diabetes remission with NAFLD. So with respect to the diet, it's mainly calorie restriction rather than the type of diet per se. That's what the advice usually follow. And this slide again is an eye opener. We can see with the percentage of weight loss and the outcome of the weight loss, the improvement in the steatosis, how many percentage, the ballooning, the lobular inflammation and NASH resolution, and even the fibrosis resolution you can see. But the sad part is that it's not the losing weight, how far it is able to, these people are able to maintain the weight loss. When it comes to that, the more than 10% weight loss, hardly 10% of the people is able to achieve even at 1 year. So that is that's a sad part of this data, and that's very important. Okay, so maintaining the weight loss is very important. So majority of the guidelines actually favor pharmacology therapy at fibrosis stage 2, F2 and more, because that's an entry point for referral. Somebody, you can make a diagnosis of F2 or more, that's a point of referral, rather than F3, because from when we see the progression of the liver disease, it takes 22 to 26 long years for F0 to F1, 9.3 years in the F2 phase, and 2.3 years in the F3. So that duration comes down. So that's why the ideal time is to refer when somebody, you can make a diagnosis of the F2 stage of fibrosis. And coming to the pharmacological therapy, there we have a definite edge over other countries. India is the only country having the first and only new chemical entity approved by the DCGI for treating NAFLD and NASH. This is saroglitazole. Actually, we are using this saroglitazole for atherogenic diabetic dyslipidemia, that is high triglyceride and low HDL, in addition to statins from way back 2013. And the new approval was got for NAFLD in 2020. So this molecule is used especially for NAFLD with a background metabolic dysfunction because of the diabetic dyslipidemia. So how it acts, let's just have a look at this is actually PPAR agonist, means it has got both PPAR alpha and PPAR gamma agonist. PPAR gamma means it is mainly expressed in the adipose tissue. So that has got an effect on the insulin sensitivity and glucose homeostasis. So it will improve the glucose disposal. It improve the beta cell preservation, thereby improving the diabetes control. At the same time, through the PPAR alpha agonism, that's in the receptors are present in the liver, kidney, heart, and muscles. It improves the uptake of and oxidation of the fatty acids and the lipoprotein metabolism. So it is useful in the diabetic dyslipidemia. So you can see the picture also, how it improves the anti-inflammatory actions and how improve both from the glucose profile and the lipid profile. And the regulatory approval by the DCGI is for NASH, NASH and NAFLD, where that has significantly reduced the fibrosis and liver enzymes. You can see the evidence as two study. The minimum treatment duration is 12 months. And this is the one slide there. We can see so many drugs which has been tried. Apart from the saroglitazole, you may be familiar with the UDCA, ursodeoxycholic acid, the OCAs, vitamin E's may be familiar, and pioglitazone and the SCL2 inhibitors. So many of these are used in the treatment of diabetes also. So you can see the saroglitazole has got the effect on all these aspects, and there is a reasonably lengthy safety data without much signals. The UDCA, the common prescription we see in most of the prescription has got no effect on any part of this entire spectrum of the NAFLD, except a transient reduction in the liver enzyme. But I told you the most of the people doesn't have much elevated liver enzymes. They are present only in a quarter of the patients. So that is not assuring. And when it comes to the OCAs, again, they has got a few side effects. Vitamin E actually is not good for non-diabetic patients. And there are risks for hemorrhagic shock and risk for prostate cancer also. So there are safety concerns regarding long-term use of vitamin E. Pioglitazone again has got, if somebody is having a biopsy-proven NASH, we can go, but the usual side effects are weight gain, edema, precipitation of the heart failure, and an equivocal bladder cancer concern. and osteoporosis and subsequent fractures, especially in the postmenopausal woman. And SGLT inhibitors again has got some urinary tract infection and genital mycotic issues. So coming to the Indian National Association for the Study of Liver 2022 recommendation, guidance paper recommendation, off-label drugs for NFLD, vitamin is not approved, pivlet is not approved, the ursodeoxycholic acid also not approved. You can see the dose of vitamin E, if it is more than 800 units for more than 2 years, there are concerns regarding the risk of prostatic cancer and hemorrhagic stroke. Pivletisone, I have already told you about the concerns. We have long data. UDC again has got a minimal effect on the liver enzymes. They don't have any effect on the histology or the fibrosis part altogether. So they are not approved. There is no data also. Their only role is for a cholestatic element of alcoholic liver disease or the cholestatic part of primary biliary cirrhosis only, because of the cholerectic action. So this is a single slide showing the European, the UK, the Asian, the ASF is Italian and American guidelines. Most of this shows that there is insufficient evidence, or the data shows that clearly they are not beneficial. All the whatever we have described, the PUFA, pentoxifilin, GLP-1 receptor agonist, obeticholic acid, silimarin. You may be familiar with the silimarin also. There's no data, no mention some of the guidelines, and insufficient evidence. Statin, they per se are useful for diabetic dyslipidemia, but not for the MASLD or such. So no improvement in the fibrosis are observed with either vitamin E or pioglitazone. Saroglitazone usually we give in a dose of 4 milligram per day. That's an approved dose for patients with NASH F1 to F3 it was approved in March 2020. And the duration of how far we can use and some of the side effects also have already told you. So these are how they accommodated MASLD into the national program, the first country globally to integrate into the national program. That will ultimately help in improving the associated metabolic disease like diabetes, hypertension, dyslipidemia, because stroke, they all together goes together, no? So that's why they have included MAFLD also. So this drug again worth mentioning, because this is the first in class and the only FDA approved drug for treating NASH. Resmetirom, or the commercial name is Resdifra, is approved for adults with NASH and moderate to advanced fibrosis. It's actually a thyroid hormone receptor beta agonist, and it works by increasing the fatty acid oxidation, which helps to reduce the fat accumulation in the liver. We don't have much knowledge about this drug. It's not available in our country, but this is the only one I could find out as an FDA approved medication apart from our saroglitazone. Lot of because for FDA approval they require much bigger data, and the saroglitazone is actually the phase 2, phase 3 trial for regulatory approval submission for NDA submission to the FDA. So right now we have saroglitazone and in the US resmetirom. That's all about the pharmacological therapy. Thank you for the patient hearing.
No, thank you very much, sir. It was a very simple but very effective talk on fatty liver. And now it's open for discussion. Any comments or any doubts, questions?
I'll ask one minute, sir.
Please.
Sir, I wanted to, sir, regarding the screening, you told that if the liver enzymes are elevated, we need to get an imaging first by ultrasound and then by elastography. So, is there any cutoff? How many times elevation should be, or like normally, as in like 5 times or something like that, sir, to cut off?
Well,
Might
that is
we
if
also
they have
require.
a background metabolic dysfunction, any condition with associated background metabolic dysfunction, and if you rule out other causes for transaminitis, then you usually proceed for, as a part of routine workup, you will proceed for an ultrasonography, especially if it persists. Transient transaminase elevation can happen, but when you control that metabolic factor, still the transaminase values are elevated, then usually we will proceed with a further evaluation. And of course, the next best option, simple option, is an ultrasonogram to find out what could be the reason for. And you can rule out the MASLD also. That's the most cost-effective way of evaluation. That's why we usually proceed with the ultrasonogram.
Thank you, sir.
Thank you, sir. Another question in the chat box. Like grade 2 fatty liver, is it reversible?
Oh yes, early part are reversible if you control the background metabolic dysfunction. Like if somebody is having obesity, you reduce the body weight, it is reversible. That's why I told it is the early part of the fibrous stage is reversible.
Okay, sir. Sir, my doubt is because we are into pediatrics regarding FIT4, age is one factor, isn't it, sir? So
Yeah.
can it be applied to children, or is there an age cutoff to apply this FIT4?
Oh yes, we can apply. No issue. It's an output.
Okay, sir. Thank you.
Sir, I have a doubt.
Please.
When we are doing this evaluation in acanthosis nigricans patients, we often see many patients with elevated SGPT in the range of 70s, 80s, 90s, and all. Youngsters like teenagers and early 20s. So, should we refer them, or should we keep them for long-term follow-up? I ask them to do exercise and do diet control, and many often that value falls back to normal. So, should we keep them on follow up, repeat SGPT?
Yeah, if it falls down, if you can keep the weight according to their height, means automatically this insulin resistance will come down. These all are expression of common soil. I told common soil hypothesis, background insulin resistance. So different expressions in different organs. The cutaneous expression, the hepatic expression. So if you reduce the insulin resistance, automatically this hepatic expression will also regress. So that sort of patients, any patient with obesity, they are always at a higher risk for progressive.
Many often some patients are not actually obese. They might be lean.
Right. Even in MASLD, around 10-20% of the patients with MASLD are lean. They can have, because they basically because of the visceral adiposity. What we usually look for is the BMI based obesity that may have got only 50% sensitivity. So 50% of the patients, we are actually not missing the diagnosis of obesity. So that's why I told that if they have a visceral component that many of us have, so then they also require a sort of examination because they have a background insulin resistance. Or else we had to calculate the insulin resistance. It's better if you go for a rather than cutaneous manifestations of insulin resistance. The most important being the abdominal girth measurement.
So should we keep them on? Should we refer them to gastro if they are not able?
I told you, I had shown a slide. That sort of patient doesn't require a tertiary care level of. There's a actually we can do an ultrasonography if required. That's all.
Okay. Okay, sir. Thank you, sir.
Thank you. Any more comments? Thank you, sir. Anand?
Yes, madam. First of all, I'd like to thank President Dr. Vinita, Secretary Dr. Asha, and Dr. Treasurer Dr. Rafida for being such an excellent leadership team and leading us all forward in this endeavor as well. Priya Madam, as always, has brought a very, very excellent guest to this forum this month, and in a very, very contemporary and very relevant topic. Right from our medical school days, we have all known any ultrasound that we do or we report or we study, everything would have a fatty liver. And it's so common that we have actually come to see it as a normal scan. Okay, only fatty liver. But the implications of fatty liver, the complications, the complications, the management, where we have to intervene, and how it is a silent epidemic, all these things are very, very contemporary and very, very necessary to learn about. And who better than Professor Ajith Kumar sir to speak about it? And sir has wholeheartedly accepted our invitation and come and delivered an excellent talk. Then it is the proof of the pudding is that we had an excellent participation today. Close to 30 people logged in to hear this wonderful session, and I'm pretty sure that everybody who have been part of the session is going back enlightened in what is a very less talked about but very, very serious health hazard in our community. Thank you so much, sir, for accepting our invite and presenting such a wonderful talk in the current AMS session. And lastly, thank you all for logging in. I know we're a little bit late in our schedule and it's already past our scheduled time, but still everybody, stayed back and logged in and stayed back for the whole talk and made this meeting a success. Thank you all. Madam, we can close the session then.
Yes, yes. Thank you, sir.
Thank you.
Thank you, sir.
Thank you, Indra.